I did not. So we're going to cover all the basics, who should be tested, what questions you can ask your doctor, and so on. So hopefully you won't get stuck falling in the cracks of the healthcare system because it's very, very possible. So if this can support you in your way, that's awesome, and that's what we're here for. We're here for getting you better as fast as possible. Okay, so my slides. Oh, here we go. Common sense disclaimer. Of course, this presentation, checklist, and any paid or free resources of Just Nourishes and IBLS, they're for general information purposes only. You can read the rest of it, but general information only. Make sure you are following up with your healthcare provider. And even though I'm a dietitian, I'm not your dietitian. So make sure you follow up with your entire healthcare team and take all this with a grain of salt. Even though it is based on my clinical practice and research, all the research studies are cited at the end of this presentation. It is not individual advice. Okay, I think we knew that, common sense. So IBS-D. IBS-D involves miscommunication between the brain and the gut, causing pain, diarrhea, and bloating. This miscommunication can change your gut movement. So abnormal gut muscle contractions can speed up food passage, causing diarrhea. This also can cause discomfort when eating, sugary meals or too much fat. So A can cause B, but not necessarily A is B. We'll get into all the layers after, such as bile acid malabsorption and so forth. So heightened sensitivity. Um, so I have the chat bar that is like right in my way. So I'm going to move this up here. There we go. Heightened sensitivity. So people may feel pain from normal gut stretching due to increased sensitivity. So if you had two people walking down the street, they both had a bean, oniony filled burrito. The one person with IBS would maybe be curled up in pain after on the couch, whereas the other person without IBS might not feel a thing and just may fart and go about their day. This is the difference between IBS gut-brain interaction and non-IBS gut-brain interaction. We all don't digest FODMAPs. We poorly absorb certain FODMAPs, with the exception of lactose. Some people can digest that completely, but we are all human and we all don't break down FODMAPs completely. So there is going to be an amount of gas uh, and stretch in the bowel, but the difference between IBS and non-IBS is the people with IBS feel this is painful when in fact we should be disregarding the regular sensations of digestion. So after an infection, IBS-D may start after a gut infection, but it can also start after a period of chronic stress or a traumatic incident. The latter was in the case for me. I get a lot of patients, their IBS started when they started university, or when they started a high stress job, or when they were going through a difficult time in their lives. So this can cause lasting changes in your gut function. Pressing the space bar. Okay, there we go. But like I said, IBS-D has the highest rates of organic disease. Not all of these are easy to test for and kind of have to go through this process of elimination. Some of them are relatively easy to test for. So let me know in the chat if you've heard of SIBO. SIBO can occur in a good chunk of us with IBS-D. Personally, I've treated myself 3 times with rifaximin, which is the standard therapy for small intestinal bacterial overgrowth, and nothing helped as much as addressing my gut-brain interaction. Everyone is different though, but just even though you see 50% there, I get a lot of people in my practice who say they've been through SIBO treatment and they still have these issues. They still have this pain and bloating and all that. So keep that in mind. It is very common in IBS-D, but it's not everyone with IBS-D. Bile acid diarrhea. Because our guts move too fast with IBS-D, we could be malabsorbing things like bile acids. Bile acids are kind of like detergent molecules that help us break down our fats, our dietary fats. And if they're not properly absorbed in the last section of our small intestine, we can get irritation of the gut lining and resulting diarrhea. Sometimes when people slow down that internal pace of their gut, they can get rid of most of the effects of bile acid diarrhea or high fat meals, but sometimes bile acid diarrhea happens because we're making too many bile acids and other reasons. So in other words, some bile acid diarrhea can be secondary to another cause and possibly resolve once the other cause is resolved, and sometimes not. But they did a study, and 25% of people with IBS-D were diagnosed also with bile acid malabsorption. Lactose intolerance, that's a good chunk of people. Usually people, by the time they come to my practice, they have a pretty good idea of whether or not lactose is an issue. But we'll get into lactose breath testing, and it's quite easy to test for. Sucrase isomaltase deficiency, that one is a sneaky one that literally just snuck up on me about a year ago in my practice. Not me personally, but seeing it in my practice. We'll touch on that later. Fructose intolerance, that's kind of a commonly known one. It's a FODMAP. People know a lot about fructose. And these are all estimated numbers because not all these numbers come from one study everyone has had the standard testing of XYZ, but these are to the best of my research. And again, all the research studies are cited at the end of this presentation. These are the numbers that I have ascertained are most likely to be relevant here in the context of IBS-D. Microscopic colitis, that is a huge one. We'll be talking a lot about bile acid diarrhea and microscopic colitis as probably the next two things that I would look into should all your limited number of laboratory tests be negative. They are sneaky things. So we'll get into that. Hypermobility. So a lot of people associate hypermobility with constipation, which is definitely more often the case. But some people with hypermobile EDS have accelerated transit, and that's about 8% that could wind up with diarrhea because of that. Pancreatic exocrine insufficiency has literally jumped up and slapped me in the face in my practice. I'm seeing so many people with PEI, especially those with diagnosed celiac disease. I know there's someone, a very lovely patient of mine who is on this presentation, who we just found out has also IBS-D and pancreatic insufficiency and celiac disease. So we know that a lot of these conditions can cluster, so we'll get into that as well. Celiac disease, there are so many better experts on celiac disease. Selena at Celiac Made Simple. Go follow her right now on Instagram if you have celiac disease. But again, celiac disease can be found as one of these differential diagnoses for IBS-D. IBD, that's inflammatory bowel disease. Crohn's colitis, that's usually diagnosed upon a scope. That's 1 to 3%. Of course, we've got the new kids on the block, histamine intolerance and MCAS. I couldn't really find good numbers as to who this affects IBS-D wise, but histamine and mast cells do have a role in IBS-D. And colon cancer, of course, we want to always make sure that's ruled out. And that happens to about 1% of people who I had originally been diagnosed with IBS, and upon further scoping, 1% of them, it's actually colon cancer. So very important. So where the heck do we start? I know, that's a lot. So today we'll cover 6 main areas: red flags, medications, blood tests, stool tests, breath tests, procedures. Again, this is not the complete possible explanations for ongoing diarrhea. There's also rare conditions like amyloidosis and so on and so forth. I won't be going deep into colorectal cancer, IBD, or things like amyloidosis that are more rare and serious forms of ongoing diarrhea. Usually it can be bloody diarrhea. So today we're focusing on basically non-bloody ongoing chronic diarrhea, what we can do about it if you're told your tests come back negative, or if you're not sure you've been tested. Where do we start? So we're going to cover these main areas. Okay, so like we were mentioning, IBS-D or chronic diarrhea can be complicated. So the very first thing we do, of course, is visit your healthcare provider. Ask them about or highlight if you have any of these red flags. If you have any unintentional weight loss, unexplained blood in the stool, if you were over the age 50 when symptoms started, that's in particular for microscopic colitis, but I've recently had one of my IBS-D program clients come back with microscopic colitis diagnosis, and she's in her 30s. So just be on the lookout. If your diarrhea just doesn't have any rhyme or reason, go get that scope and biopsies. But over the age of 50, though, typically can increase a person's risk of microscopic colitis. If you have a family history of bowel disease, tell that to your doctor, tell that to your GI. You might be eligible for earlier screening for colorectal cancer, and in fact, you should be. Or family history of IBD or celiac disease. If you need to wake up to have a poop in the middle of the night, classically IBS sleeps when we sleep. usually, unless you have another layer to your IBS. But in general, when we're unconscious, it's not possible for our subconscious to overly sense the sensations of regular digestion, which is very common in IBS-D. So you shouldn't be waking up overnight in pain or having a bowel movement. And if you are, you got to tell your doctor. If you have fever, if you have iron deficiency anemia, if you have iron deficiency anemia and you're always low iron and always keeps dipping and you're unresponsive, please believe me, there's probably a reason for that. So I have that starred there because that is a big red flag, especially for those with um, some nasty things like celiac disease and so on and so forth. Vomiting, that's not really part of IBS-D. So if you're vomiting, head to your doctor, red flag. Persistent severe daily diarrhea. And if you have obviously a palpable mass in your tummy or your abdomen or swollen lymph nodes, those are all red flags. So head back to your healthcare provider. Medication review. I can't tell you how many times we have a client who comes in with a diagnosis of IBS-D after, increasing medication. So there's an excellent presentation yesterday on GLP-1 receptor agonists. Those can either cause diarrhea or constipation and other GI effects. But just so you know, medications cannot be understated as to their potential impact on gut speed. The biggest ones that I see are the SSRI antidepressants. So the escitalopram, fluoxetine, sertraline, etc. Um, the gout medication is listed there. I'm not going to even try to pronounce it, but it's there. Apparently that it can be implicated in diarrhea, metformin, and so on and so forth. If you've been treated with clindamycin or certain antibiotics, your diarrhea might be related to C. diff. We'll go into testing, of course, for that. Certain proton pump inhibitors can cause diarrhea. Anything that ends with Zol, ACE inhibitors, NSAIDs, ADHD stimulant medications. Hello, Vyvanse. That one I had to get off of because that was making my gut run too fast. I don't know if anyone else can relate who also has ADHD, but that could be a very overlooked medication, especially now that we have a little more awareness and diagnosis of ADHD and beta blockers and metformin, which is a specific diabetes medication. So, and other ones there. If you're taking too much magnesium to sleep at night, or that Sleepy Girl drink, which has cherry and magnesium, I have had clients who've been taking that and have no idea why they have major diarrhea. Yes, that is not really probably the most recommended sleepy drink I would have for someone with diarrhea. So, oopsies, did I skip one? Medication review. Okay, there we go. Blood tests. In addition to other testing and your history, these tests can give you clues as to the root cause of diarrhea. So go over with your doctor. Have you had a complete blood count? Have you had any blood taken since this all happened? You'd be surprised how many people just soldier through and then don't ever go to the doctor and get blood work. That is starred because it is required before an IBS-D diagnosis. Ferritin, of course, we want to know if your iron is that sort of red flag. Is it too low? Um, and thyroid stimulating hormone, even though it's not required before an IBS diagnosis, I highly recommend that you get it done because if your thyroid is making if you have hyperthyroidism, this can lead to diarrhea. So too much thyroid hormone speeds up the gut. CRP, C-reactive protein. This is a general marker of inflammation. It can't diagnose any one condition, but this is starred because it can help give us clues as to if what you're experiencing is an infection or inflammatory in nature, and it's in general showing up in your blood, something to be addressed there. So the next blood test we're going to look at, micronutrients. Excuse me again, just coming off a cold. I'm going to have a little sip here. Okay, micronutrients such as vitamin D, B12, folate. Why do we test these? Well, if there's some damage going on to your digestive tract, you may not be absorbing your food and nutrients properly. So you may see decreased amounts of certain nutrients depending on the condition that we're looking at. So if we're looking at, for example, pancreatic insufficiency, this could you could be losing too many fats and not digesting your fats, and that's how vitamin D can be lowered because it's a fat soluble vitamin, so those can be impacted. But if you have damage from your something like celiac disease or an infection or etc., those can also lower um, your micronutrients that you can find in blood work, such as these. And B12 is a tricky one. So B12 and iron can be used as a nutrient by bacteria, and also bacteria can make folate. So higher low levels of these in the context of everything that's going on in your digestion can help us piece together a little bit more of what's going on with you in that body of yours. What are some possible clues? Again, this isn't ticked off as required, but I highly recommend that you go for the gusto. And in Canada, you have to pay an extra 75 bucks to get your vitamin D analyzed, but it is well worth it in order to get a accurate picture of what is going on. Blood test continued. Okay, celiac disease. If I had a nickel for every time someone came to my IBS practice and they had not had a thorough I, celiac serology done, I would probably very rich. So celiac disease is about 1% of the population. It's a chameleon disease. It doesn't have only diarrhea. You can be constipated. You can have zero symptoms whatsoever. You can have just the symptom of, constantly dropping iron, for example. So this is absolutely crucial to get clear is if your celiac screen has been complete. A complete celiac screen is as followed. If you include gluten in your diet for at least 2 slices of gluten per day for several weeks before this blood test, you have to have gluten in your diet in order for this blood test to be accurate. You also need to have a certain amount of this IgA antibody in there. Some people have lower amounts of this antibody, and you can see in the top right corner who might have lower amounts of this antibody, and they might need to get an alternative test. So make sure that your serum IgA is also included with your TTG for your celiac screen, that you're eating gluten and you have not discontinued gluten before this test. And so this is the number one test I see incomplete by the time people have an IBS diagnosis, either because they weren't eating gluten at the time of the test because they'd already cut it out, or they didn't know they needed to put it back, or they just never had this test done at all. So keep in mind, even if you have a negative TTG, about 5% of those people will actually go on to get a scope and may possibly have celiac disease diagnosed via endoscope. Again, you need to still be including gluten in the diet, and celiac diseases is more common in those with IBS, so be on the lookout. So if you do get a positive TTG, that might indicate the need for an endoscopic biopsy to confirm celiac disease, which is the gold standard. Okie dokie, celiac disease, make sure it's complete. Stool tests. This is the number one test that I see not done at all before an IBS diagnosis. In Canada, the reason probably why is it's an additional $143 cost. Please still get this done because I've had numerous fecal calprotectins come back positive, which means that there is likely inflammation in the lower GI tract. So inflammation can come from inflammatory bowel disease, Crohn's, colitis. It can come from other sources of inflammation as well. Um, and you know, this is this is just critical, and I don't know why it's just not more well known. I didn't know about it when I was diagnosed with IBS-D. So yeah, fecal calprotectin is a stool test. You're gonna have to put plastic over your toilet and go poop in it and collect your stool, and it's gross, but my goodness, it is very, very necessary in order to be clear of if the source of your diarrhea has anything to do with inflammation in the lower GI tract. So keep in mind, it can miss inflammation occurring in higher up in the GI tract. So at times it's not the most reliable for inflammation in the entire GI tract, but it is something that we can easily test, and it can be a very valuable piece of information. So yes, take the cost of $143 to see if there's anything in there inflammation wise. Okay, stool test continued. Fecal elastase. This isn't a required test because pancreatic insufficiency happens in about 6% of people with IBS diarrhea. But, if you have ongoing diarrhea and you're seeing, floating stools or greasy looking stools, or you notice your flare ups are particularly bad after a higher fat meal, I've seen some people who don't even have diarrhea at all, and their fecal assays came back really bad in the last month alone. So, pancreatic exocrine insufficiency, or PEI, does not look only like diarrhea, but it is often found in diarrhea. I think it's like 60%, 67% of people with PEI have some form of diarrhea. The biggest thing I want to say about fecal elastase, which I found out maybe a couple months ago, is that the official cutoff for pancreatic exocrine insufficiency. So this is when your maybe I should define this a little bit. This is when your pancreas is kind of being lazy. It's not doing enough of work to put enough digestive enzymes into your digestive tract to break down your fats, your proteins, and your carbohydrates. When these aren't being broken down properly, typically it's the non-digested fats that cause the biggest amount of issues. So, though the official cutoff for pancreatic exocrine insufficiency is anything below 200 micrograms per gram, one recent study showed that 71% of patients who had a fecal elastase that was above 200 but below 500 showed symptom improvement with treatment, which is pancreatic enzyme replacement therapy, or PERT. So if you have ever had a fecal elastase, by the way, if you have ongoing diarrhea and all the other tests we've covered, your fecal calprotectin, your CRP, your complete blood count, your celiac serology, those have come back normal and you still have ongoing diarrhea, I would invest in a fecal elastase. I believe it's free here in Canada. I'm not sure about anywhere else. In BC, it's free at least. Um, I would get this done. And if you have a result that is 236, 280, and your doctor says it's normal, it's true. Technically, it is in the not pancreatic exocrine insufficiency range, but according to that study and based on several patients of mine who have had fecal elastase ranging from 204, I've had a 239 this week, 280, they are responding to pancreatic enzyme replacement therapy. If you are getting a little bit of pushback, you can remind your doctor that PERT, pancreatic enzyme replacement therapy, is a quite a safe treatment to trial, um, because that could be one very simple thing to do. Typically, people are treated with about, and it's based on lipase units, about 25,000 to 50,000 lipase units per meal, which means you're taking capsules of enzymes at the beginning of the meal and the mid meal. And if you feel better, less bloating, less GI discomfort, then likely this is one of the biggest pieces of your unresolved GI symptoms, possibly including diarrhea. So, insufficient pancreatic enzyme production can lead to bloating, low vitamin D, diarrhea, potentially unintended weight loss. It can happen in those with celiac disease or other autoimmune conditions. They tend to cluster. Crohn's disease, ulcerative colitis, HIV, elderly populations, chronic pancreatitis, and so forth. Um, so do note that if you know you have pancreatic exocrine insufficiency, you're on pancreatic enzyme replacement therapy, and you're still super bloated, there's a few things that you need to go over with your healthcare provider, including dose, adding a PPI, and potentially, and I just found this out on Monday under my GI supervision, but apparently the pancreas also, I know the pancreas also emits bicarbonate, which I didn't realize is very necessary to keep bacterial overgrowth in check in the gut. So if you have PEI, chances are you may also have SIBO, or intestinal methanogen overgrowth, small intestinal bacterial overgrowth, etc., because of the lack of antimicrobial activity in those who have pancreatic exocrine insufficiency. That's a lot of words. Make sure you ask your questions in the chat. Hopefully I was very clear on that. Stool tests. So it's funny how this isn't required per the literature before an IBS-D diagnosis, but I think we often overlook things like Giardia and C. diff. So just so you know, there's stool tests available that can screen for certain parasites in their eggs and other issues in an infectious diarrhea panel. So if you've ever had that test done, great. If you haven't and you have ongoing diarrhea, possibly after, drinking contaminated water, went out hiking, or, possibly, food poisoning, or after a round of antibiotics, maybe this is quite a important test for you to look into. And a word on GI map testing. So far, based on everything I've seen, heard, and read, it's not a reliable test in the context of IBS-D. This is another stool test that a lot of people sell. It's quite expensive. And the reason why it's not reliable in the context of IBS-D at this point is because there's no agreement on what a healthy microbiome can be defined as at this time. Um, and it also only assesses the microbiome found at the end of the GI tract, from what I gather. So the the small bowel microbiome is very important too, and it doesn't have the ability to test all parts of the gut. But, I have seen clients go ahead and do the GI map test because it also includes a fecal elastase and fecal calprotectin. I don't know if these people who run these tests have the same laboratory and testing, standards as those at, going to your doctor and getting there have. However, one of my clients recently look back on her fecal elastase that she took on a GI map test, and I was um, interested to see that it was actually showed pancreatic exocrine insufficiency. And indeed, we are looking into PERT therapy for this patient now. And so I'm not sure how accurate the fecal elastase and fecal calprotectin is on GI maps, but they are included, and in the context of all your symptoms, could be helpful if you've already had it done. But if you haven't already had a GI map done, don't get a GI map done. Just get the actual evidence-based test done at this point. It's what I would recommend. Breath tests, lactose breath tests. So if you are unclear as to if lactose is a part of your story, you can go and get a lactose breath test. This is an evidence-based test. What I realize now, which I didn't realize before, is it needs to be at least 3 to 4 hours in duration. Um, some tests come back at only 2 hours and it'll be negative for lactose intolerance. And then I'll have patients be like, oh, but I thought there was an issue with lactose. I'm surprised at this. Some people, well, a test that's 3 to 4 hours in duration can at that point tell us what's going on in the large bowel, because there's a certain amount of time it takes for food to get from your tummy to your bowel. It's faster if you're in a fasted state and you're drinking a liquid, but the test for the lactose breath test, it should be at least 3 to 4 hours in duration to allow for time for that lactose substrate to get from the mouth to the tummy to the several feet of small bowel and into the large bowel for if they has an increased amount of fermentation, there'll be an increased amount of gas, hydrogen gas, I believe is what they measure there. And if it's above, I think it's like 20 parts per million. Someone can remind me in the chat. I think I see Marley there, Marilee. But if it's above that, a certain threshold in 3 to 4 hours, that is a positive for lactose intolerance. Oh, I didn't have my square very close to that line there, but the next breath tests we'll talk about are those for SIBO and IMO. So there's hydrogen, methane, and hydrogen sulfide breath tests available. The most common one I see is hydrogen and methane. These tests for if there's too many gut bugs overgrowing in that gut of yours. These are particularly indicated for those with diarrhea and lots of bloating or gas, and or low B12 and or high folate. And if you wanted to ask your doctor or advocate for yourself for treatment of, a possible gut dysbiosis, in the context of IBS-D, there's an on-label medication for a medication that's on-label use is for IBS-D, because it's so well understood that IBS-D, we tend to have high rates of dysbiosis. So rifaximin, I'm not sure if anyone's heard of rifaximin. Zaxine is the generic name. Xifaxin is what it's called in the States, I believe. But if you have ongoing IBS-D, you're particularly bloated, an on-label use for this medication is IBS-D. In Canada, it doesn't have a on-label use specified for SIBO, so just be careful if you're looking to get this claimed under benefits or patient support from it. But if the reason for its prescription is IBS-D, you're more likely to get this covered, and there's a patient support program there to get you some money off because it's a very expensive antibiotic. But if you are unsure, if you want to see the data first, you are absolutely more than welcome to, on your own dollar, because in Canada we don't do this in clinic. In the States, I believe you can, but you can order one of these breath tests. I believe they're like 225 bucks. You drink a solution after being fasted overnight, breathe into a tube every 15 or so minutes. And if there's hydrogen methane at certain amounts during the test at certain timings, um, then there's a little more evidence to point to if you might have one of these bacterial overgrowths. Like I said, I've been through rifaximin 3 times because I was convinced there was an organic cause for my diarrhea, and all 3 times it was great while I was on it, and then diarrhea always came back. So keep in mind, it might be because it needed to be paired with something like N-acetylcysteine, which they're doing lots of research now about. Otherwise, it also could just be nothing to do with gut bugs. So yeah, keep in mind. Additional tests and procedures. So these are not, it's not required that someone has a scope in the absence of those red flag features. But if you are offered one, great. um, so about 10% of those with IBS-D, when they're scoped with biopsies, randomly taken throughout the intestine, they may be found to have microscopic colitis. So if you're like, oh, I've had IBS-D, I've had a scope before, but they didn't say I had any sort of colitis or microscopic colitis, please look at your report or get the report from your doctor and see if if they took biopsies while they're scoping you. If you have unexplained diarrhea that's not responding to anything, you've had a scope before, but they never took biopsies, this could possibly be missed. Microscopic colitis is such a sneaky thing because of this fact that you need to not only go and scope a patient, but even if your inside of your intestinal lumen looks all healthy and beautiful, you may still have microscopic colitis. They need to sample and look under the microscope. It's called microscopic colitis for a reason, and the inflammation is only visible sometimes at a microscopic level. So I had a patient who's suffered with diarrhea for 56 years. She's had, I think it's like 3 to 5 scopes. I can't recall the exact number, and none of them at any time did any biopsies for microscopic colitis, which is, so if I can make anyone not have diarrhea for 56 years, with the tip that you might need some biopsies when you go for your next scope, or get re-referred to GI to get another scope done ASAP to get these biopsies and scopes in your scope, then yes, please be aware of that. And about 20% may have bile acid malabsorption. We talked about that. The CCAT test is available, I believe, in BC here. I don't think it's available so much in the States, but maybe it depends on the state you're in. But more often than not, if we suspect bile acid diarrhea here, we'll do a trial of a medication called bile acid sequestering medications. So I don't know if any of you in the call here have ever been on cholestyramine, colesevelam, but these are examples of bile acid medications. So besides rifaximin, Zaxine, as a medication trial for IBS-D, my next suggestion would probably be a trial of bile acid sequestering medications and chatting with your doctor about that. Because yeah, it's quite common. And again, though, how much of that is everything is just moving too fast? It's unknown. There's no studies right now of, those who are treated with, bile acid sequestering medications or the need of them before and after something like gut-directed hypnotherapy to slow down the gut. And there's lots of different causes for bile acid malabsorption, from primary to secondary, or lots of causes. So, but a medication trial for that is definitely something you can chat to your doctor about. So colonoscopy, of course, we want to have your terminal ileum inspected. If there's damage there, that's where your bile acids are supposed to be reabsorbed. If there's damage or inflammation there, it might not be doing a really good job at it. If you've had your gallbladder out as well, that you're at higher risk of bile acid diarrhea. I don't think I put that in there though, but just hot tip. And then while they're scoping, they should assess the health and presence of your ileocecal valve. That's a little kind of gatekeeper from your small intestine to your large intestine. If that's not there, if it's damaged, such as say you've had your appendix out and they also took your ileocecal valve out, then you don't have this little trap door that stops bile acids from coming in their own free will, and that can increase someone's risk of bile acid diarrhea. So, and again, biopsies taken across all sections of the bowel, microscopic colitis. All right, that is testing. So to sum, how am I doing for time actually? Ooh, that's a lot of talking. To sum, because IBS-D has the highest rates of organic disease compared to the other subtypes of IBS, if your diarrhea is ongoing, consider having a discussion with your doctor about, this is bare minimum, red flag symptoms. That's always, and please never leave those out of your discussion with your doctor. Reviewing all your medications, checking the blood work basics. That's your complete blood count, your iron studies. I would throw in a thyroid stimulating hormone, a TSH, CRP for inflammation, your micronutrients for a little more clues, your celiac serology. Were you restricting gluten at the time? Do you have an autoimmune condition that might make this measure unreliable? And so on and so forth. Do you have a family history of it? You might need to scope with biopsies to be sure. Stool tests, fecal calprotectin at minimum. If you have ongoing, diarrhea after contaminating, drinking contaminated water or hiking or something, stool parasite ova is an obvious one to me. And fecal elastase if you have a history of autoimmune conditions or any of the other issues. If you're losing weight and unexplained losing weight and or low vitamin D, fecal elastase, fecal elastase, fecal elastase. And breath tests, if you're unclear about lactose, there's an evidence-based breath test. If you want to know if you have high hydrogen or methane, that's a SIBO breath test. But again, IBS-D, on-label use for Faximin. You don't need to take a breath test. Well, you shouldn't have to take a breath test. I've had some doctors require you to take a breath test before taking that medication, but you shouldn't have to. Additional tests and procedures as needed per your GI and your doctor, such as repeating colonoscopy if biopsies weren't taken to screen for microscopic colitis, for example. That's where I would go first. If you meet the Rome 4 criteria for IBS-D, which is, and I have to read my sheet because I always mess this up. Recurrent abdominal pain for more than 1 day a week on average in the previous 3 months associated with at least two of the following: pain related to defecation, change in frequency of the stool, so you're going more, change in stool form or appearance of stool, so it's getting looser. Again, this is the context of IBS-D. And if you haven't had any red flag features and you've completed complete blood count, iron studies, CRP, celiac disease test or screen, excuse me, and fecal calprotectin, research estimates that this is accurate in diagnosing IBS-D as such. IBS-D, 56 to 70% of the time. This doesn't mean you don't have any other layers, but it is fairly accurate in diagnosing that disorder of the gut-brain interaction. And 76% of the time, an accurate diagnosis, 56 to 70% of the time isn't great, but it isn't actually that bad either, because there's something we can do about it. Addressing your IBS-D is a disorder of the gut-brain interaction. One steps to ensure the testing basics are complete. You can resolve, through multimodal care. There's a 6-month program that we offer. It's multimodal. It combines gut-brain work, soluble fiber therapy, and limited dietary restrictions with the aim of getting off all dietary restrictions. And through, for example, one of those legs, gut-directed hypnotherapy alone, 4 out of 5 patients with IBS report an average symptom improvement of 60 to 75%. And that's better than any medication for IBS to date. But that is all barring you've been tested and worked up properly. The more convinced we are that you've been adequately worked up, the more likely it is that this is IBS-D, and the more likely you're going to respond to IBS-D therapies. So, the program that I run, IBLS diarrhea, it can also provide you with key information, meds, suggestions, supplements, suggestions, relevant diet trials, should you also have some layers to your IBS. So there's some guidance on SIBO, bile acid diarrhea, lactose intolerance. There are test diets for sugar, sucrase osmia maltase deficiency. So that's that issue with being able to break down sucrose and starch. So if you went low FODMAP and you find even chicken, rice, and carrots bugs your gut, I would consider sucrase isomaltase deficiency, because those are natural sources of sucrose and starch. But otherwise, that would be normally considered a completely low FODMAP meal. So that would be a good tip there. Or if you have your worst diarrhea days after eating sugary foods or candies or sweets. Fructose intolerance, we've got test diets for that. And it also can give you a little more insight as to, could this be microscopic colitis or pancreatic insufficiency? We also have test diets for histamine intolerance in IBS. Okay, here's a bunch of resources that this presentation is based off of, right there. And I will ask Tanya to pause the recording.